I'm Bob Greenspan, and welcome to this podcast. If you find history a bit boring, as I do when presented in terms of just names, dates, and facts, then perhaps you might find it a bit more meaningful to be able to join those who were there at the time through their images and words and by seeing the actual instruments and medications to which they were exposed. You will be meeting lots of folks in these podcasts, so let me first introduce myself. I practiced medicine for 47 years before I retired about 7 years ago. I treated all sorts of medical conditions, but I chose to specialize in diseases of the kidney because that gave me an opportunity to maintain a relationship with my patients, sometimes for years and even for decades, while they were on dialysis and after they received a kidney transplant. I'll be starting each podcast with a quote from a past physician. The first I chose is Dr. William Osler, whose 19th century Principles and Practice of Medicine was the first modern textbook of medicine. More importantly, he was responsible for establishing the bedside medical training program we still use today, and he was the type of caring physician I've always admired.
The practice of medicine is an art, not a trade, a calling, not a business, a calling in which your heart will be exercised equally with your head.
Despite all of their pills and potions, the only true contribution early physicians made to the survival of their patients was through a timely amputation, even though about 40% survived the procedure, only to be faced with the subsequent risk of infection. For that reason, 16th century German surgeon Hans von Giersdorf advised that all of his patients go to confession and that they receive the Holy Sacrament prior to surgery. With no effective treatment for gangrene or the ensuing sepsis, some very strange concoctions were introduced by surgeons. One of the most bizarre by 17th century surgeon Dr. Kenelm Digby with his wound salve. The ingredients included earthworms, pig brains, and powdered mummy, but to be effective, the salve needed to be applied both to the wound and to the weapon that caused it. This is an illustration of an amputation from the 1497 edition of von Giersdorf's surgical field manual, Fieldbuch de Wuzendrie. Note that the surgeon uses his left hand as a tourniquet to control bleeding and also to compress nerves to reduce pain. The decision to amputate was not taken lightly, so famous 16th century French surgeon Ambroise Paré described the signs that justified that procedure.
You shall certainly know that a gangrene is turned into a mortification, and that the part is wholly and thoroughly dead, if it look of a black color, and be colder than stone to your touch, if there be a great softness of the part, so that if you press it with your finger it rises not again, but retains the print of the impression, if the skin come from the flesh lying under it, if so great and strong a smell exhale that the standers be cannot endure or suffer it, if a green or blackish flow from thence.
The fear of not only losing an arm or a leg, but of losing one's life must have quickly accelerated to terror after one look at some of the amputation instruments about to be used. This is a 19th century Italian surgical set made by Fugini. Notice a large amputating saw with wooden handle that could not be sterilized. Additionally, there's a bone forceps and a hammer and chisel. At the top, you'll see a small hook. That's called a tenaculum. When you see a tenaculum in a surgical set, you know it's medical and it's not a butcher set, since they use that little hook to pull out vessels to tie them off. It's sometimes difficult to date surgical instruments, but these can be seen in use in the 1655 edition of Armamentarium Chirurgicum by Sculptatus. Let me show you some of those scary instruments I just mentioned. Imagine yourself being wheeled to the operating room by 4 strong men facing surgery with no anesthesia, and then seeing your surgeon pick up one of these. This is a 16th century German amputation saw. Notice the 2 hooks on the ends. They were hung by the surgeon in front of their offices for display. Later on in the 18th century, this is an amputation saw by Savigny from England. A French-style amputation saw by Spear and Jackson was this style. Notice they're all wooden handles. This has an ebony handle, which was very common. Getting into the 19th century, many physicians used ivory. This one was made by George Tiemann. Now, Tiemann is a company still in action in New England. They made some of the finest surgical sets throughout the 19th century. And again, this is an ivory Tiemann surgical amputation saw. An 18th century metacarpal saw. I'm not sure where this was from, but imagine the time and effort that went into carving, and if you can notice, there's actually a hand engraved on the handle for amputating fingers and hands. The most immediate danger facing those who had to undergo an amputation, and the major challenge to their surgeons, has always been the control of bleeding. Certainly no device has been more popular for that purpose than the use of the tourniquet. In 1718, Jean-Louis Petit devised a metal screw device he named the tourniquet. And this is an example of that screw device. A 17th century clamp, arterial clamp. And then for major extremities, other tourniquets, this is a large tourniquet for an upper extremity amputation to control arterial blood flow. And then for a lower extremity, even larger, here's a device, a screw device that was used to control bleeding in the 19th century. I wanted to show you an illustration of these clamps and tourniquets in action. The illustration I'm showing you is from what I believe is the finest illustrated textbook of surgery that I've run across. The authors are Bourgerie, Bernard, and Jacob, second edition of Traité complet d'anatomie de l'homme, 1866 to 1871. You'll see several of these illustrations throughout these podcasts. Before going further, I do need to mention ligatures or sutures with which we are familiar today. They were first used by 16th century surgeon Ambrose Paré. This is the 17th century tenaculum I mentioned, used to reach vessels so they could be tied off during surgery. Paré's preference was to use catgut, and his discovery was much to the relief of those who could avoid what at the time was the most feared but most effective way to control bleeding, the cautery. One reason for the popularity of the cautery was that unknown physicians at the time was the fact that this procedure was an excellent way to control infection. This illustration is from Hans von Giersdorf's 1517 Vierbuch der Wüstenrede. William Clowes was the surgeon to Queen Elizabeth and once said, "The iron is most excellent, but it is offensive to the eye and bringeth the patient to great sorrow and dread of the burning and smart." This is an early case set of cauteries. Lawrence Heister was the preeminent surgeon of the 18th century. This was his description of the use of the cautery in his A General System of Surgery, written in 1718.
Cauteries are made of very different shapes and sizes, according to the parts to which they are to be applied. There are two inconveniences which generally attend the use of the cautery, and sometimes force us to neglect it. For first, not only the patient is usually wonderfully terrified at the apprehension of it, but mankind in general look upon it as a piece of barbarity, when to say in truth it does not occasion such violent pains as are usually apprehended from it, and what pain there is in the operation is instantly over.
There were two ways to perform an amputation, the circular and the flap techniques. The circular method was the older one and was preferred by military surgeons because there was less operative pain and the wound healed quickly since there was less soft tissue to be exposed to the possibility of infection. The procedure was still quite painful, as can be deduced in this oil painting by the number of strong attendants required to restrain the patient. This is an 18th century circular amputation knife by Price with a sharp edge on the concave side. Dutch physician Herman Boerhaave will describe the method of a circular amputation in 715 while I show you an illustration by Bourgeret.
With a sharp, strong, crooked knife obtuse on the back well tempered, which is thrust under the leg till it comes to the place where the operator began, which makes a circular incision cutting all the flesh to the very bone. Then is the bone divided with a fine, sharp, fine, strong and straight saw, which is to be moved first gently but then strong and equally and always perpendicularly.
The other amputation technique was by the flat method, which was preferred by some since it could be done more rapidly and there was much less postoperative pain. Following is an illustration of that flat method by Bourgeret, accompanied by physician Ashurst's personal account in the 1896 Boston Medical and Surgical Journal of the horrors he experienced during his own pre-anesthetic amputation.
I at once agreed to submit to the operation, but asked a week to prepare for it, not with the slightest expectation that the disease would take a favorable turn in the interval or that the anticipated horrors of the operation would become less appalling by reflection upon them, but simply because it was so probable that the operation would be followed by a fatal issue, that I wished to prepare for death and what lies beyond it, whilst my faculties were clear and my emotions were comparatively undisturbed. The week, so slow, and yet so swift in its passage, at length came to an end, and the morning of the operation arrived. The operation was a more tedious one than some which involve much greater mutilation. It necessitated cruel cutting through inflamed and horribly sensitive parts, and could not be dispatched by a few strokes of the knife. Suffering so great as I underwent cannot be expressed in words, and thus fortunately cannot be recalled. The particular pangs are now forgotten, but the blank whirlwind of emotion, the horror or great darkness, and the sense of desertion by God and man bordering close upon despair, which swept through my mind and overwhelmed my heart, I can never forget, however gladly I would do so. Only the wish to save others some of my sufferings makes me deliberately recall and confess the anguish and humiliation of such a personal experience, nor can I find language more sober or familiar than that I have used to express feelings which, happily for us all, are too rare. During the operation, in spite of the pain it occasioned, my senses were preternaturally acute, as I have been told they generally are in patients under such circumstances. I watched all that the surgeon did with a fascinated intensity. I still recall with unwelcome vividness the spreading out of the instruments, the twisting of the tourniquet, the first incision, the fingering of the sword bone, the sponge pressed on the flap, the tying of the blood vessels, the stitching of the skin, and the bloody dismembered limb lying on the floor. Those are not pleasant remembrances. For a long time they haunted me, and even now they are easily resuscitated, and though they cannot bring back the suffering attending the events which gave them a place in my memory, they can occasion a suffering of their own and be the cause of a disquiet which favors neither mental nor bodily health.
Robert Liston was a prominent early 19th century Scottish surgeon who popularized the flap technique. He was the first to perform surgery using anesthesia outside of the United States, and he invented a number of surgical techniques and instruments. This is an image of Dr. Liston holding an instrument now named after him called a Liston amputating knife. He was a large man who was a legend in the operating room for his speed in amputating a limb, a skill very much appreciated in the pre-anesthetic era. The stories regarding Liston's operating technique were many, including the notches he carved on his knife after each amputation. He would hold the major artery with his left hand and make one great cutting pass with his right. With the knife held in his teeth, he would then suture the wound, the whole procedure lasting just a few minutes. On one occasion, while Liston was trying to break a speed record for a leg amputation, he accidentally amputated both of his patient's testicles. On another procedure, he cut off his assistant's fingers and slashed the coattails of an observer. Unfortunately, the mortality was 3, since not only did the patient die, but so did his assistant lose his life from gangrene, while the observer reportedly died of fright. There were 2 major discoveries in the 19th century that changed the course of surgery and, in fact, the course of medicine in general. The first was the successful use of anesthesia in 1846 that allowed surgeons to enter areas of the body never before accessible, including the abdomen, the chest, and the brain. The story of anesthesia is a fascinating one, but one that'll have to wait for a later podcast. The other major turning point in the history of surgery was the realization that the microorganisms seen by van Leeuwenhoek under his first microscope could cause disease rather than the previous believed explanations which included inflammation, the spontaneous generation of organisms from inorganic matter, and miasma, which was a term that was given to invisible airborne matter. Physicians believed they could protect themselves from those dangerous substances simply with fragrances. For example, in the 17th century, they put flowers in the nose of plague masks, like this one, presumably to protect themselves. Malaria was prevalent in wet, mosquito-infested swamps, so the name malaria means bad air. Without knowing why, early physicians found that the use of wine, vinegar, and honey reduced the number of post-operative deaths. But the modern story begins with French microbiologist Louis Pasteur, who proved that the organisms first seen under the microscope could in fact cause disease. German physician Robert Koch took the story to the next level when he proved that microorganisms in fact were the cause of anthrax, tuberculosis, and cholera. His postulates have become the medical standard required to prove the etiology and the transmissibility of infectious diseases.
The microorganism must be found in abundance in all cases of the disease, but not in healthy individuals. The microorganism must be isolated from the diseased host and grown in pure culture. When the cultured microorganism is introduced into a healthy host, it must cause the disease. The microorganism must be re-isolated from the experimentally infected host and identified as being identical to the original specific causative agent.
Despite all that was known regarding the transmissibility of infection, there remained stiff opposition to using surgical aseptic techniques in the 19th century, as witnessed by Scottish surgeon Lawson Tate.
Through the folding doors, what a difference. Everywhere hurry and untidiness but much dirt. The wards stank. The operating table was of wood and of fabulous age. The only correct garb of a surgeon was a frock coat, the oldest and shabbiest in his wardrobe, which was kept in the surgeon's room and never renewed or cleaned during his 20 years of operating work. The surgeons came direct from the dissecting room to operate. Ligatures were used, which had already been soiled by handling with blood-stained fingers, to bind up wounds in a second case. And at Edinburgh these ligatures were always worn ostentatiously by the house surgeon, like a badge of knighthood in the buttonhole of a coat, which often rivaled that of his chief for dirt.
In England throughout the 19th century, British surgeon Sir Frederick Trevis experienced the same high post-operative mortality figures while he was at the London hospital.
Owing to the separating wounds, the stench in the wards was of a kind not easily forgotten. I can recall it to this day with unappreciated ease. There was one sponge to a ward. With this putrid article and a basin of once clear water, all the wounds in the ward were washed in turn twice a day. By this ritual any chance that a patient had of recovery was eliminated. I remember a whole ward being decimated by hospital gangrene.
Professor Samuel Gross was one of the most prominent surgeons of the 19th century. He was the chairman of surgery at the Jefferson Medical College in Philadelphia, and was also the founder and first president of the still active American Surgical Association. In 1859, he wrote a 2-volume text entitled System of Surgery, which became an important reference during the Civil War for both the North and for the South. Unfortunately, despite all of the available knowledge regarding the importance of aseptic technique, during surgery, he continued to believe in the inflammation theory of infection.
Inflammation may be defined to be perverted action of the capillary vessels of a part, attended with discoloration, pain, heat, swelling, and disordered function, with a tendency to effusion. In addition to these changes, there is also an altered condition of the blood and nervous fluid as an important element of the morbid process. In what inflammation essentially consists It would be idle to inquire, since it would be just as impossible to unravel its true nature as it would be to explain the intimate character of attraction, repulsion, gravitation, or cohesion. Hence, in studying its history, all that we can do is to examine its causes, symptoms, and effects, or more properly speaking, to institute a rigid analysis of its appreciable phenomena. If we endeavor to step beyond this, we shall, like our predecessors, lose ourselves in the mazes of conjecture and hypothesis, those quicksands upon which so many of the noblest minds of the profession have, in all ages since the origin of medicine and surgery, been wrecked and stranded, as if to warn us of their folly and the impossibility of further progress.
Dr. William Williams Keene was one of the first neurosurgeons and an editor of Surgery, Its Principles and Practice. He was a surgical consultant to Presidents Calvin Coolidge and Franklin Delano Roosevelt. Dr. Keene worked with Dr. Gross and described the operating room in a 1915 New York Medical Journal article.
We used only the ordinary marine or toilet sponges. After an operation, they were washed in ordinary water to cleanse them of blood and pus, and were used in subsequent operations. In our ignorance of bacteriology, we did not know that they harbored multitudes of germs which infected every wound in which they were used. Before an operation, nothing was rendered sterile by antiseptics, or by heat, boiling, baking. I have seen more than once my old teacher, Professor S. D. Gross, give a last final touch to his knife on his boot, even on the sole, and then at once use it from the first cut to the last. When threading a needle, all of us pointed out silk by wetting it with germ-laden saliva and rolling it between germ-laden fingers. It was 7 times safer to fight all through 3 days of Gettysburg than to have an arm or a leg cut off. What a contrast is the surgery of today.
Samuel Gross was 70 years old when he was approached by 31-year-old Thomas Eakins to appear in a portrait that was to represent American surgical excellence at the upcoming 1876 Philadelphia Centennial Exposition, which was the first World's Fair to be held in the United States. Despite the fact that the painting is now recognized as one of the most superb examples of American portrait art, the Centennial Selection Committee rejected it, ironically because it was too graphic and they felt not appropriate to display. Note that while performing an infected bone resection in order to save the patient from an amputation, Gross and his assistants were wearing street clothes with no interest in asepsis. Recently, the National Gallery of Art was interested in acquiring the painting from Thomas Jefferson University, but as citizens of Philadelphia refused to let it go and were able to raise $68 million to keep the painting on display in Philadelphia, now jointly owned by the Philadelphia Museum of Art and the Pennsylvania Academy of Fine Arts. Joseph Lister was a late 19th century British surgeon who was at the forefront of aseptic surgery, leading to a revolution that has saved the lives of millions. He recognized and incorporated the important contribution that Louis Pasteur made when he showed that microorganisms could be the cause of what had been termed suppuration in wounds. Surgery became a much safer procedure with Lister's use of carbolic acid as a sterilizing agent. He performed the first successful case of aseptic surgery on August 12, 1865, when he operated on the fractured leg of 11-year-old James Greenlease, and the world of surgery was sent in an important new direction. Noted British abdominal surgeon Berkeley Moynihan was knighted in 1912 and served as president of the Royal College of Surgeons from 1926 to 1932. He illustrated the sometimes literally painful transition to sterile technique when he described this scene in 1888.
The surgeon arrived, doffed his coat lest he should soil it with blood or pus, rolled up his shirt sleeves and took down from the cupboard in the passage leading to the theatre an old coat, as a rule a frock coat of antique design which bore many marks of usage, and was stiff here, there, and everywhere with blood. One at least of the coats was worn with special pride, indeed with a certain jauntiness, for it had been inherited from a retiring member of the staff. The cuffs were rolled back a little, just above the wrists, and the hands were washed in a basin. The hands, when clean in a social sense, were soaked in a solution of carbolic acid. The instruments were taken from the cupboard and placed in a tray of 1-in-20 carbolic acid about half an hour before the operation. When all was ready, the spray was turned on and a fine mist of steam, odorous with carbolic acid, soon bathed all engaged in the operation.
William Halsted was one of the most prominent surgeons of the 20th century and has been called by some the father of American surgery. He, along with doctors William Osler, Harvey Cushing, and Howard Kelly, were responsible for establishing the Johns Hopkins School of Medicine with the residency training program he began that is still in use today in all American medical schools. Halsted made significant advances in thyroid, biliary tract, intestinal, and arterial aneurysm surgery, but he's probably most remembered for his first use of gloves in the operating room. That turned out to be an accident when his nurse assistant and future wife, Carolyn Hampton, complained of skin irritation.
In the winter of 1889 and 1890, I cannot recall the month, the nurse in charge of my operating room complained that the solutions of mercuric chloride produced a dermatitis of her arms and hands. As she was an unusually efficient woman, I gave the matter my consideration, and one day in New York requested the Goodyear Rubber Company to make, as an experiment, 2 pair of thin rubber gloves with gauntlets. On trial, these proved to be so satisfactory that additional gloves were ordered. In the autumn, on my return to town, an assistant who passed the instruments and threaded the needles was also provided with rubber gloves to wear at the operations. At first, the operator wore them only when exploratory incisions into joints were made. After a time, the assistants became so accustomed to working in gloves that they also wore them as operators, and would remark that they seemed to be less expert with the bare hands and with the gloved hands.
In 1826, George Tiemann moved from Germany to New York City to set up the George Tiemann Company for the manufacture of surgical instruments. That company produced some of the finest instruments throughout the 19th century, and they are still in business today, about to celebrate their bicentennial anniversary. By coincidence, Tiemann's 50th anniversary in America coincided with the 1876 U.S. Centennial World's Fair exhibition held in Philadelphia. Tiemann handmade this award-winning gold-engraved amputation set with mother-of-pearl handles and 50 small rubies to mark that anniversary. Their instruments were award-winning despite of the fact that surgery was well into the aseptic era by that time. There remained a demand all the way until the turn of the century for instruments made with ebony and ivory handles that could not be sterilized, which doctors could take pride in and display to their patients. Here's a late 19th century ivory-handled case surgical set by Tiemann that was popular with physicians much longer than it should have been. George Bernard Shaw was an Irish playwright and critic, as well as a political activist. He lived and wrote throughout the transition period in medical practices that I've been describing. In his 1911 article entitled The Doctor's Dilemma, Shaw related the frustrations and anger directed toward the medical community during those changing times.
Now it cannot be too often repeated that when an operation is once performed, nobody can ever prove that it was unnecessary. If I refuse to allow my leg to be amputated, it's mortification and my death may prove that I was wrong, but if I let the leg go, nobody can ever prove that it would not have mortified had I been obstinate. Operation is therefore the safe side for the surgeon as well as the lucrative side. It is not the fault of our doctors that the medical service of the community, as at present provided for, is a murderous absurdity. That any sane nation, having observed that you could provide for the supply of bread by giving bakers a pecuniary interest in baking for you, should go on to give a surgeon a pecuniary interest in cutting off your leg, is enough to make one despair of political humanity. But that is precisely what we have done. And the more appalling the mutilation, the more the mutilator is paid.
A few remarks as I end this first podcast. In 2000, I was disappointed to find that there were no medical history books which allowed me to really understand past medicine through the images and words of those who were there, so I decided to write a book. I knew nothing about how to proceed, and unfortunately, I couldn't find a publisher since they were only interested in a commercial venture with the usual names, dates, and artifacts, so I decided to do everything myself. The writing, publishing, typing, editing, arranging, the printing, the marketing, the photography, and the distribution. Fortunately, the project was saved with the guidance of a brilliant graphic designer, Linda McKnight. These podcasts are an extension of that book, and once again, I started from scratch, not knowing anything about this form of communication, but with the same intent in mind. There are lots of interesting folks to meet, including Dr. Samuel Gross, who seems to have gone through a similar experience to mine when he wrote the book I mentioned earlier. The following quote is from his 1887 autobiography. Thanks for joining me, and I hope to see you next time.
I generally spent from 5 to 8 hours a day upon my manuscript, subject, of course, to frequent and sometimes annoying interruptions by patients.